So welcome you all to the disease information series talk 1. So today we'll have a round panel discussion on one of the most prevalent disease, which is hypertension. So I welcome our panelist Mr. Anil Kumar, Associate Professor, Department of Pharmacology, Dr. Sheikh Faizan Ali, Assistant Professor, Department of Pharmacy Practice, and also Dr. Santosh Kumar, Assistant Professor, Department of Pharmacy Practice. So welcome you all for today's discussion.
Thank you. Thank you.
So I'll start my first question with Anil Kumar sir. So can you detail us about what basically this hypertension means?
We all have been hearing of this particular BP. Okay, so we generally as blood pressure, okay, or hypertension as we call it as clinically. So this BP or hypertension is defined by the JNC 8, Joint National Committee 8, particularly as a BP, a range of, okay, we generally know that it is systolic and diastolic BP. So it is defined as systolic BP of 140 and more and diastolic BP of 90 and more, or if a particular patient is taking antihypertensive medications. So in such condition we call that as hypertension. And we should always keep in mind that this definition is not a standard definition for anything. Always we have to take into consideration what are the comorbidities. So for example, a patient has congestive heart failure or he has diabetes. So we have a small change in the definition. So I would say rather than a particular definition, when we say hypertension, it is that range of BP generally which will lead to end organ damage or risk. So that range of BP we can call it as hypertension.
Okay. So something where we call 140 by 90, which is systolic by diastolic, and more than that we call it as hypertension.
Right.
So we always hear that it is very common in India and in worldwide. So how common is hypertension, Ali sir?
Actually, when we consider seeing the Indian statistics, it is about 17 to 21% among all the Indians. But that prevalence rate is usually varies depending upon the etiological factors if we consider it. For example, if we take any age, so when we are looking at the age, people who are having 70 years or above are more prone to hypertension. For them the prevalence rate is about 67%, and latter occupies 50 to 60 years of age people, they are about 63% of prevalence. And other etiological factors like obese people, when compared to a normal individual having the correct BMI, the person who is having overweight and obese people are more prevalent to blood pressure or increased blood pressure and hypertension. It's about 25%. And some studies also showed that community where we live also make more prone for hypertension. For example, people who are living in urban areas are more prevalent to hypertension when compared to people living in rural areas.
Okay.
Just like that.
So I think your data says that almost 60% of elderly population generally suffer with hypertension.
Yes.
So which is very big. So can I know from Santosh sir, what could be the initiating factors of hypertension?
Yeah, when we're talking about initiating factors, I think we can relate it to risk factors generally. So we can categorize into two things: modifiable factors and non-modifiable factors. So modifiable factors means which we can really change. Okay. Those include physical inactivity, unhealthy diets, or habits like drinking, smoking, etc. Such things we can modify them actually. When coming to unmodifiable, like those are certain things which we cannot modify. For example, age factor we cannot really modify it. So people who are above 50 to 60 years age, definitely they are prone to this. The major risk factor is there, along with family history of hypertension. Such things, they really play an important role. The prominent importance to discuss these initiating factors or risk factors is, if at all we look at the recent WHO guidelines 2021, what the data says is, when we compare the statistics in 1975, all over the globe, there are about 560 to 570 million people are suffering from hypertension. But when we see the data in 2020, according to WHO recent guidelines, the number have increased to 1.5 billion people. So that itself says the importance to look at the area of modifiable risk factors. If we focus more on these factors, definitely we can try to control such things. Yes.
Yes, agreed with you totally, because we need to focus more on modifiable rather than things which are not in our hand.
Yes.
At this point, I really feel that certain screening is very essential for people at particular age. So what are your general recommendations, Anil sir?
So we have been seeing, and also during our childhood we used to play. So we all know sphygmomanometer,
Yes.
right? So sphygmomanometer is a basic and standard measurement tool we have. So now normally these days you have been seeing some electronic machines, okay, which can automatically measure BP, but there is a error of 10 to 20%. So even now, so basic sphygmomanometer, we use mercury manometer. So that sphygmomanometer is the basic screening method, and there are a few things we should take care when actually we are measuring this BP. So screening is always screening should be done at least for 3 clinical settings. Okay. So clinical setting is one time you go to a doctor. So we say that is a clinical setting. So it should have at least 3 clinical settings, and you should have a gap of at least 1 week. So we may be worrying or wondering why this is. So normally if you don't give any gap, there may be chances of white collar hypertension.
Yes.
You see a doctor, there may be an increased BP, so which is normal, which is not hypertension. And second thing is, the patient may be in a hurry, he may have an emotional stress, whatever it may be. So we should avoid all these variables so that you get the correct value before you directly jump into conclusions. So what we try to do is, we try to ask the patient to come to the hospital or measure this BP at least thrice. Okay, and every time you measure, there are different positions you should measure. So in sitting position, standing, and also in lying position, and every position you should take it thrice. Okay, so there are further things. So this may be difficult in clinical settings, so you can measure it at home. Okay, and while you measure, generally we measure for both the hands. And even for 3 clinical settings, if your particular physician, okay, feels that so it is more than 140 systolic. So nowadays guideline says, most of the times the present guideline or JNC 8 says, so or it is more stressing upon the diastolic rather than systolic. More than 90, so it is saying it is BP. So your therapy always depends upon so the range of BP. So and whenever you are measuring, so take gaps and also different positions, and also while measuring this BP, should ask the patient to calm down and see that no isometric exercise is being done by the patient. Okay, you should not do any exercise. So you should always ask the patient to keep his arm properly on a any table or whatever it is. So there is no exercise. So you take all these readings, then average them, and even then after 3 sittings you find out that the BP is high, then you say, or by that screening you say the patient is having hypertension.
It was very simple to say that there is raised in BP,
Right.
but the screening is it follows a lengthy protocol.
Yes.
Actually. So one more question to Ali sir. So as said by Santosh previously, which talks about modifiable and non-modifiable. So during treatment of a patient, how important is history and how it can relate with hypertension?
History plays a vital role while treating in any disease, not only in hypertension, because the exact etiology, we cannot rely only on the pathological condition of the body. By history taking, we can find out what is the main cause for that pathological condition in that patient. For example, by consuming increased salt intake, the blood pressure usually rises. And we all know that in India we mostly prefer chutneys and pickles. While in Western country they do not encourage much, but in India without chutney it is not possible. So increased sodium intake, salt intake is higher here. So dietary habits and their lifestyle, how they are leading. Sedentary lifestyle usually causes raised blood pressure, and what type of their body conditions and family history. because it is from genetics or any other diseases that the patient is experiencing, like kidney diseases, like hormonal changes. Sometimes even the neurological disorders plays also vital role in managing blood pressure, because blood pressure is usually managed by either kidneys or by the regulatory mechanism of nervous system. So we have to see the underlying diseases also. So even the stress also causes the same increased blood pressure. So that's why while taking history, it is important to take everything, even including the diet, the lifestyle he lead, and the diseases he is having, and the diseases present in his family.
So you are trying to say that there is a lot of things to be taken, to be considered while diagnosing of the hypertension.
Yes.
So my next question is to Santosh sir.
Yes.
So from the previous information, we can come to a statement that it is very complicated to identify hypertension, even though it is not entirely linked with just systolic and diastolic. So it is not what other investigations can help in the diagnosis of hypertension.
Yes. When we're talking about investigations, primarily we have to see how much is the blood pressure reading initially that we'll be seeing with sphygmomanometer readings. There are certain other things we need to take care of. For example, number one, ambulatory monitoring. It is a 24-hour monitoring process. The physician will suggest you to monitor your blood pressure 24 hours completely at regular intervals in a day. That gives you an accurate measure of blood pressure, like how much it is varying throughout day and night. So that is one test we have to regularly have. Initially we have to go through it. Apart from that, we need to go to other laboratory investigations and ECG also. These other laboratory investigations like serum creatinine, lipid profile test, or urine dipstick, or this ECG, these all investigations, they rule out the comorbidities. For example, serum creatinine, if the value is very high, something it tells about chronic kidney disease the patient is suffering from. If HbA1c value is high, it tells that something, there is a problem with the diabetes mellitus, the blood glucose levels of the patient, there is something problem. So we need to rule out all the aspects. Particularly importantly in case of hypertension, cardiovascular disease risk stratification is really important. Further, we need to go through the lipid profile test, etc. So these are some of the investigations that physicians will order.
Okay, thank you. So maybe a next question to Anil sir. So since it is very complicated to diagnose, is there any chance of misdiagnosis, and how we can come out of that misdiagnosis of hypertension?
Definitely, that is important, and this answer may be an extension to what Santosh sir was saying. So you need to rule out a few things, okay, as we have been discussing. So it should not be a jump to the conclusion. Always we have to look for what are the other things which are involved and which seems to be hypertension, okay, which is not hypertension in the patient. Most of the initial things we should look into are the endocrine abnormalities. For example, the patient have hyperthyroidism, hypothyroidism, or the patient have a tumor in the adrenal gland. So such things. So when he has a tumor in the adrenal gland, it may pump out adrenaline. More adrenaline is into the blood circulation, and we call that condition as pheochromocytoma. Okay, so this condition, there may be a rise in BP because there is a lot of adrenaline in your blood circulation. And other drugs like amphetamine, normal NSAIDs like naproxen, etc. So these drugs also, there are a very wide or extensive list of drugs which may increase BP, and always we should take care that these drugs are not included in the prescription, or check before you diagnose that the patient is in hypertension.
Okay, so diagnosis should not only be depending on increased of BP, but it should be ruled out. We need to rule out certain conditions which should not interfere with the diagnosis. So next question to Ali. So once everything done and we have finalized the diagnosis, so what different treatment options you'll have in your hand for the treatment of the patient?
So for treatment of this increased blood pressure, we have two types of options. Mainly one is involves drugs, which we call it as the pharmacological treatment, and another one is where drugs are not involved. We call it as non-pharmacological treatment. First, let's see about non-pharmacological treatment. It usually patient suffering from the increased blood pressure are recommended to follow the DASH diet, means low sodium diet. They are advised to take a less sodium when compared to normal people. In general, we take 4 grams. These people were advised to take 2.2 grams per day. And depends upon the condition. If he's having some comorbidities like that, he will be asked to take even less or restrict totally. And which foods like which may cause increased rise in the blood pressure, like alcohol and smoking. These causes some of the disorders which may lead to the increase in the blood pressure of the patient. That's why they will be asked to limit for the intake of soda, alcohol and smoking. And the person will be asked to do some exercises, not tremendous exercises, going to gym and walking, doing so much, but a little bit increased, so that some metabolism get corrected, and it may control the raised blood pressure to the lower value. And maintaining a healthy weight, as we have said in the earlier, obese people and overweight people are having more prevalent when compared to the normal BMI people. That's why maintaining healthy weight plays a vital role in controlling the blood pressure. And healthy lifestyle leading, sleep, and stress management. So for that, sleep is at most important. Nowadays people are running only after stress. So stress management, which regulates the neurological functions, so that blood pressure comes to the normal, the right blood pressure decreases. So next, when giving to the pharmacological treatment, most of the times it depends upon the cause. When we see the epidemiological data, secondary hypertension is less prevalent. Essential hypertension is more prevalent. Exactly, we may not know the cause, but we have to trace out the mechanism by which the blood pressure is getting raised than the normal. Depending upon that etiological factor, we can our pathological condition which is increase in the blood pressure, we have to prescribe the medications. For example, if raised blood pressure is due to the renal causes, means kidney function is not proper, or maybe due to kidney hormones are releasing excessively, which is causing the raised blood pressure, then we have to prefer drugs that acting on the kidney, like diuretics, 81 angiotensin receptor blockers, or angiotensin converting enzyme inhibitors. Or if patient is suffering from atherosclerotic disorders like blocks in the valves, so any other like that, for that we have to prefer beta blockers. If he is having atherosclerosis and diabetes, then we have to go for ARB only. Depending upon the etiological factor, we have to change. If the person is having heart muscle disorders and is suffering from arrhythmias, irregular heartbeat, then we have to prefer the drugs which acts on the heartbeat mechanisms. For example, we take calcium channel blockers. If the person is suffering from any neurological disorder, or due to hyperactivity of neurological conduction, which may lead to raised blood pressure, we have to prefer like beta blockers or alpha and beta blockers. And newer some drugs are also available, like renin inhibitors, which is showing very much effectiveness in some patients, inhibiting very good. And some are having like coagulation abnormalities. So for that persons, we can prefer for vasodilators, like the drugs depending upon the causating factor, pathological condition which is leading to increased blood pressure than normal, we have to prefer the drug.
Okay.
When we follow to JNC 8 guidelines, it generally recommends ARB and ACE inhibitors.
Okay.
Later on, beta blocker and calcium channel blockers.
Okay. I think we have lot many options in
Yes.
the treatment of hypertension. So an extension answer I'm expecting from Santosh sir. So can you just emphasize on special recommendations for special individuals? Maybe, as you said, diabetes and CKD are most common causes which we see with hypertension. So, is there any particular special protocol for the treatment of those patients?
Yes, we can definitely relate this question to your earlier question of my investigations, which I told there about the comorbidities which we need to really look about, like diabetes mellitus, it can be chronic kidney disease, it can be, like rightly Ali sir said, there are three major classes which are involved in a lot of conditions which we generally use. For example, when we're talking about specific groups, here patients with hypertension without cardiovascular disease, that is one group. Patients hypertensive with cardiovascular disease, that is one specific group. Patients with hypertension with chronic kidney disease, that is one thing. And there are some other cardiovascular disorders, like rightly said by Ali sir, atrial fibrillations or left ventricular hypertrophy, any such other conditions also. We need to look into such specific groups. For example, if we take, there is a hypertensive patient with coronary artery disease. We need to start our first line with beta blockers. Along with lifestyle modifications we'll be doing, however, for stage 1 people, stage 1 hypertensive people. Suppose if it is a stage 2, we need to go to the dual therapy. Monotherapy may not be sufficient for such people. So in dual therapy, we will be going with beta blockers and calcium channel blockers in such specific groups. For example, if the patient is hypertensive without any cardiovascular risk, in such patients, we will be going initially with thiazide diuretics as a first line. Then, or apart from the thiazide diuretics, we can go with ACE inhibitors or angiotensin II receptor blockers, or even we can go alone with CCBs also. Why I'm mentioning here CCBs, like calcium channel blockers, a prominent role here. See, according to the recent guidelines by World Health Organization, they told one important point. There will be many remote places over all the world where non-clinical settings, like where diagnosis cannot be taken care immediately. In such cases, in such places, we should not delay the treatment. We should not wait until the report comes, or we should not delay the treatment. So in such cases, WHO told you can start with calcium channel blockers initially, and then when the reports come, if you really feel like to change the regimen or the treatment part, then you can go with other drugs, like it can be angiotensin receptor blockers or ACE inhibitors or any other diuretics, etc. So that is the importance of looking after these particular specific groups. And also, if the patient is really suffering with a chronic kidney disease and is hypertensive, then we need to go with the first line therapy with ARBs and ACE inhibitors in the first line agents. Suppose if that is not working, then we have to go to the second line, dual therapy. In dual therapy, we will be going with ACE inhibitors or ARBs, along with thiazide diuretics will be going. This is one specific group. So like this, for each and every comorbidity, there is a different treatment approach. Apart from that, there is another important point between the blacks and the non-blacks. Particularly when we are talking about hypertension, we need to discuss this because, there is some genetic thing. So in case of blacks, we can directly go with thiazide diuretics or calcium channel blockers. Here, ACE inhibitors or angiotensin receptor blockers are not preferred initially. After the test, after the risk factors are evaluated, after the comorbidities are evaluated, then we can change the therapy. But initially, in blacks, we have to go with thiazide diuretics or calcium channel blockers. Even in combination therapy also, we can give both of them.
Okay.
That differs with case of non-blacks.
Okay.
So this is how we generally categorize specific groups.
It looks the treatment of hypertension is very complex.
Yes.
And it is so recommended that not just to use drugs without the consultation of a doctor or a physician.
Absolutely. Investigations play a key role here.
Yes. So maybe my next question is for Anil sir. So since we are talking from long ages about ACE inhibitors, ARBs, beta blockers, is there any new emerging treatment that has been seen from the recent years regarding hypertension?
Yeah, apart from these drugs, ABCDs, okay, apart from these drugs, so we have other drugs which are in pipeline, and also there are some drugs which are under clinical trials.
Okay.
So these may not be useful for all the patients, but these are patient specific. we cannot use them in normal conditions or normal clinical settings. There are a few things I would like to just address. One thing is the chronotherapy. So chronotherapy, as we know, chrono is time. Okay, so if you try to take these drugs at night time, chrono is time, so this is at bedtime. Some clinical trials have proved that if you are taking, so generally it will be BD or TID 2 times or thrice 3 times a day. So if you have take at least 1 dose during bedtime, it is said that BP is much better controlled. So one is the chronotherapy, and second thing is denervation of sympathetic nerves which are supplying the kidney. So we cut down the sympathetic stimulation to the kidney so that RA system is controlled. So this is one type. And the third one is drugs. So some newer drugs have been, or you can say repurposing of drugs have been taking place. So some other drugs used for diabetes, like the glucose, sodium glucose transporter 2 inhibitors. So these drugs can be used for BP. So there is an indirect action where they will be acting to control glucose. So by controlling glucose and maintaining the body weight, etc., so it also controls BP. So this is one particular indirect therapies. So other drugs like amiloride, so it is a potassium sparing diuretic, so it is also widely being considered for BP. So there are other new drugs, so like inhibiting enzymes which convert angiotensin 2 to 3 in the brain. So we call that as aminopeptidase A inhibitor. So these drugs also which decrease the amount of angiotensin 3 in the brain so that we can decrease BP. So there are some new emerging drugs, so some pharmacological, some non-pharmacological things which are under consideration.
Maybe I agree that humans never compromise with the scientific temper.
Right.
So even though they have strong identified drugs, still a lot of research is going on in hypertension. Maybe it's a good sign of drug research. So maybe next question, a part of treatment, a part of drugs. So can you suggest few things which can help in preventing hypertension?
Yeah. But prevention usually depends upon the factors, especially the etiology that is causing the high raised blood pressure. So some are modifiable and some are really not modifiable. Like age, we cannot modify the age to the younger
Yes,
person.
absolutely.
Like that. If the person is having some family history of hypertension with cardiovascular diseases, we can't modify the gene before birth. So obviously he is going to suffer. But what we can do, we can increase. If the person is having family history, he may get the hypertension at 30 years of age. But if we maintain lifestyle modifications and some preventive measures, he may or may not get. But we can delay. Instead of 30, he may get hypertension 50, 60, which is a good thing for that. First of all, in that lifestyle modifications. So what is lifestyle modification means? Nammak kam karna. नमक नहीं तो सालन में मजा नहीं ऐसा नहीं चलेगा. First, decreasing of sodium, so salt restriction and decreased salt intake is the best option. And after we have to do some physical work, increase the physical work so that some metabolism takes place and blood pressure also. Get some healthy lifestyle being. Instead of juices, we have to take some fruits like that. If we maintain the healthy weight and restrict some salt diet, so that we can prevent to a lot of factors and lot of diseases, and not only hypertension. Because even though nowadays patients are using this number of pharmacological drugs, they are facing resistant hypertension. What's the major factor? Means this non-pharmacological only. Lifestyle modification. Patient is not following lifestyle modification. He is ready to take 3 to 4 drugs, but he is not ready to leave the pickle. That's the major problem for resistant hypertension. If they are able to control the diet and follow some lifestyle modifications, maybe hypertension is preventable. That's
I think from your words, which we used to say that prevention is better than cure. Rather than that, prevention is also better than progression of a disease.
yes.
Yes.
So maybe because we are running out of time, straight question to Santosh sir.
Yes.
So can you please, in a short way, can you tell us what could be some counseling points you could provide to your patient?
Yes, like Alisa said something about sodium, reducing of sodium intake, etc. We can also refer to there is a terminology, DASH diet. So DASH stands for dietary approach to stop hypertension. So this is a very simple diet. We need to monitor regarding this diet, because there are many recent research studies have proven that if we follow this diet, definitely there is a significant improvement in the blood pressure within 2 to 3 weeks after following this DASH diet. So we need to have a look on this definitely, and it is a very simple diet, like eating more vegetables, taking low saturated fats, or cut down the saturated fat, which are cut down the foods which are really high in saturated fats, etc. Such things we need to cut down. And also we need to take something like we need to cut down, we need to limit the intake of sodium, we need to limit the intake of sugary things, sugary substances. Those things we need to cut down. And also when we're particularly talking about sodium, it should be less than 1.5 gram per day. It is highly impossible. At a stretch, we cannot really come to 1.5 gram per day. Generally, we'll be taking around 5 gram per day through our regular general foods. So on a regular basis, we need to cut down from 5 gram to 1.5 gram or even less. It is a very good thing to follow up. So these are some of the counseling points. But most importantly, as hypertension is a long-term disease, medication adherence is important, along with lifestyle modifications. He told many lifestyle modifications regarding physical activity or dietary approaches, etc. But medication adherence is also equally important, because it is a lifelong treatment process, right? So that is one aspect I wanted to add.
So before ending today's session, maybe extended question to Anil sir. So as it is a lifetime process, as Santosh sir said, so what could be will it be any protocol for the follow-up? Is it necessary to have some follow-up or?
Absolutely. So generally there are two types of follow-ups. So one follow-up is particularly on the comorbidities which are having. So we cannot just focus on hypertension. So follow-up should be done on, so the patient is having any cardiovascular risk. So we generally, if the patient is smoking, alcohol, etc. So we should look what is the cardiovascular risk. So we have different calculations for measuring this cardiovascular risk. Apart from that, because he is taking a lot of sodium or other things, so there may be risk to the kidney. So we have to measure the creatinine levels, okay, and also to see whether he is taking the medications properly or not. And if you want to change the medication, so generally the review is done for every 6 months to 12 months. And the measurement of BP is the most important, actually, what we are talking about. So you have to measure this BP periodic. If the patient can measure daily, it's good. So otherwise, at least for every 2 to 3 weeks, the patient should go to the physician, okay, and he's in a clinical setting, he should measure what is his BP, okay, if he cannot do it daily. And second thing is drugs. So if he's going on taking other drugs also, so there should be a continuous monitoring on, so if there is an impact of these drugs on the therapy you're taking. So one thing is the comorbidities, second is thing is the drugs you're taking, and review on the continuous increase or decrease in the BP for every 2 to 3 weeks.
Okay, so which means you want to say that rather than going with treatment alone, there should be some follow-up sessions which need to take frequently, so in order to prevent his mortality or morbidity.
Right.
So finally, we are end with this today's session on knowledge information on diseases, talk series 1, and I will have a continuation of this talk series for several other conditions, and that's all for today, which is on hypertension. And I take this opportunity to thank our 3 panelists, Anil Kumar sir, Ali sir and Santosh sir, for their time and for the information.
Thank you.
Thank you all. Signing off, yours Babiraj.
Thank you.